So it's my pleasure now to, I nearly walked off and didn't introduce Catherine, I apologise, to introduce Catherine North. She doesn't need any introduction. I'm sorry, I'm just going to repeat your line there because she's so famous. And she's been a great partner in the Australian Genomics Consortium with us in Genomics England and is the leader of the national initiatives here. Catherine.
Thanks so much, Mark. What I'm going to do today is give you an update on what's happening in Australian genomics and where it's going in the future, but also really emphasise how we're taking on the standards of the Global Alliance in partnership with other countries. So Australian Genomics commenced about 2.5 years ago as a 5-year program, so we're at the halfway point. And it was very much funded by our National Health and Medical Research Council as a health services research project with a focus on demonstrating through pilot studies patient benefit from genomic testing, providing evidence for cost effectiveness, practical strategies for implementation, but at the same time as we're doing all of this, building the research translation capacity in Australia. Australia is a federation of states, so we have to think about federation right from the beginning of what we do. And what you can see along the bottom timeline, along the bottom timeline here, is that the cities in our different states, our hospital system is funded through our state governments, whereas our federal government funds Medicare and primary care and funding of different tests and medications. So it's a bit of a schmozzle when it comes down to getting that federal and state partnership from a funding perspective. And so we had a number of state initiatives that had been formed, particularly, obviously, from where I live. I was very involved with Melbourne Genomics, which is led by Claire Gaff. But what we saw early on is, I believe when our rail system was first built, that the trains had to change tracks going from one state to another because the gauges didn't match up. So we did not want that to happen again. And we wanted to make sure that we weren't duplicating activities and that we're thinking about genomics as a whole of nation approach. And so we started with a number of roundtables in 2014. We're all raring to go and one cohesive, loving mass of people by the time that Australian Genomics started in 2016. And the whole goal was that we would be mapping and piloting approaches, sharing models and standardising our practices and policies as we went along. So we started as a partnership of 40 institutions around Australia when we first got funded, and that included all the clinical and diagnostic labs in each state for genetic services. We've doubled in size over the last 2.5 years, so we now have over 80 institutions and we have over 400 investigators around the country. And obviously all the way along the sort of timeline of this has also mirrored our involvement with the Global Alliance. So it's been great to do both of those things hand in hand because it's very much informed what we've done in our country. This is our basic sort of overview of what our health services research program looks like. But what we did was to do it prospectively, along the lines of what Genomics England has also done. Rather than going back and sequencing the DNA of patients we have in our freezers, we were setting up the network so that as patients came in to present in different disease areas, they were recruited into the Australian Genomics, and then we were able, within a research basis, to start to look at the implementation of genomics, look at the diagnostic utility of various approaches, and to then evaluate how successful that had been. So we had a number of rare disease and cancer flagships, but prospective recruitment, which means we're having to train our workforce and upskill our clinicians so that they're genomics literate as we go along. That is underpinned by an infrastructure of a national diagnostic and research network, which I'll give a little bit more detail. We've piloted our approaches to data federation and analysis, but we're keenly watching what is happening in other countries. the area of evaluation, this is about demonstrating value and working very hand in hand with both our federal and state governments to convince them they should invest in genomics, as well as the ethical and legal issues that we need to deal with. And then finally, as I said, trying to increase what we're doing to address the dearth of people that we have in genetics counselling, in bioinformatics, and to upregulate clinician skills in genomics. This is what the overview is, but this is what it really looks like. All of these different boxes represent different working groups. Down the left-hand side, these are all of the different rare disease and cancer flagships across different disease areas. The flagships are really looking about evaluating whether we take things from panel to exome to whole genome to RNA-seq, and how we build a clinical pipeline that's relevant to a specific disease area. And we have disease-specific networks in all of these disease areas. We've changed we've changed in response to need as we've gone along. We've developed a national clinical genomics consent. We're now looking at dynamic consent because there's certainly been an express need for that. And I won't go through all of these boxes, but our team that's led by Tiffany Bortwood will be organising about 900 meetings this year of the different working groups. So it's quite a production. I think what we now have in place, and this took about 18 months, was setting up an ethics and governance structure that represents every state and territory. And these are the points of where people come in for recruitment. And that required sort of national ethics but individual governance in the different sites that are involved. But what it's meant is that we've cut down the time. It took sort of 12 to 18 months to get some of these ethics up and running. But now we've got quite short turnaround time as we introduce new disease flagships, getting down around 3 months. So this is incredibly useful. And we fund staff and project coordinators and counsellors in each of these sites to make sure that the data collection that we're aiming to do is happening. What the dream is that Australia, as a small but proud country, will present within the world as a single cohort of 25 million people, and that we're collecting and recording and using and evaluating all of our data in the same way. What we're aiming for, and what we actually, I think, have achieved in many areas, is a common consent, the common national ethics, that we do quality control across our different diagnostic labs, common informatics pipeline, really rolling out and training up genomics literate clinicians. This is a very interesting part of what we've been driven to do, I must say. It wasn't in our initial plans, but we do a lot of work now in implementation science. And this is data that's hot off the press. Is led by Jeffrey Braithwaite and his team. They looked at the networking, this is of medical scientists, genetic specialists, medical specialists and researchers. And this was before Australian genomics actually started in 2016, and it was really looking at who did you interact with and who did you know before Australian genomics, and there was about 2,900 connections. Whereas this is what it looks like now, 2.5 years later, and this is the groups of people that are involved across Australian genomics, and there's now triple the number of connections between researchers and specialists because of the networks and all of those meetings that we've set up. We have set up in parallel a functional genomics network. So we just had our second meeting, bringing together about 200 scientists working in rare disease functional genomic areas. And so what we've set up is like a matchmaker, so that if clinicians are finding new genes, novel genes, variants of interest, we can then plug them into scientists that are interested in the same areas, in the same pathways, and using relevant model systems. We're very much stealing from the Canadian model here of Genome Canada in terms of really trying to bring the science and the clinicians together. The last year there was a number of extensive amounts of work done around policy and government engagement with our federal government, particularly to set up a national health genomics policy framework for how genomics would be rolled out as a state-federal partnership into the future. And then these more aspirational roundtables looking at the future of precision medicine. And the happy news out of this, much like Mark's happy news, is that in our budget earlier this year, our federal government has given $500 million for genomics going forward. And now remember, our health system is a federal-state partnership, and actually most of the genetics action actually happens funded by the state governments. So our goal now is that this will be a federal-state partnership, and my dream is to double this as a budget over 10 years, so that we're having the state governments also investing as we roll this out to the health system. This is but this is also funding from our Medical Research Future Fund. So what we're looking at is that they will be really embedding building up a lot of the functional genomics, disease mechanism, therapeutics work, and that the state governments will be investing in terms of the rollout and implementation into practice. I feel if I say that enough in public forums, it will become so. So what next? For Australian Genomics, we will, of course, roll seamlessly into the genomics mission as it goes forward. But a lot of what we're doing over the next couple of years, the next year or two, as the genomics mission also rolls out, is making sure that we're really enhancing this sort of cohesiveness that we've developed. And I think what's most exciting me at the moment is we're really going into some new areas, looking at reproductive, how do we take reproductive carrier screening at a genomic level to a population scale. That's one of the pilot projects that we're rolling out now, is one of the first investments from our health minister as part of the mission. So just to finish, I would like to then emphasise what the Global Alliance has done for us and what we do for the Global Alliance. When we look at all the driver projects, all of these different names are really relating to a lot of people who are in this room, because we're making sure that we have that involvement usually at odd hours of the night in the different workstream telephone conferences, and that we are taking back into what we're doing in Australia the learnings of the Global Alliance, so that this year, for the first time, as we planned our work in our Data Federation data analysis program, everything was aligned with what was happening with the Global Alliance. So it's been incredibly useful for us, as has this sort of integration with the national initiatives and learning what's happening in different countries. Just as an example, if we look at all the different stages of a patient's genomic data journey and look at the program logic that we've developed from the Australian genomics perspective, what we're really doing is implementing the standards of the Global Alliance at every step. So we're sort of lucky from a timing perspective that we're sort of building it as the Genomics Global Alliance is producing it. And finally, I think both Augusto and Mark have referred to the partnerships that we've developed with Genomics England. And these are relatively young. It was in actually at the meeting in Toronto, we all sat down and said, come on, we've been talking about it for long enough, let's just bloody well do it. And let's actually have different members of our groups going to spend weeks and time embedded, and as it's been the case, particularly with Zanetza and Clara in Genomics England. And these are the things we identified that we could really share in terms of expertise. Where the ones I'll just comment on are really looking at the education evaluation framework, and really then what we're doing in terms of clinical and phenotypic data capture and the virtual gene panels that Augusto has been working on. But we've really identified all of these other areas, and the goal eventually is that we can just plug England and Australia into one another and have our data moving seamlessly between the two countries. Another dream. So from an education perspective, I mean, it's been amazing how much Genomics England and the NIH have invested in education in genomics. And so Clara Gaff here, who leads Melbourne Genomics and is also the co-champion of our driver project in Australian Genomics with me, has brought together genomics educators and is really looking at how do you evaluate what's good in education in genomics, how do we make sure that what we're doing is making a difference. And now the evaluation framework, which is on this next page, and Clara, who's, put your hand up, Clara, in blue down here, I'll be very happy to talk to you about this, but it's currently being tested and used to look at education tools in a number of different countries so that we're developing, I guess, and building the standards for what is needed to give adequate genomic education. See, I even will stop myself. Finally, this has been incredibly useful, and I actually, after our talk on the national initiatives yesterday, I've had a couple of people come up and say, can we get our hands on what is the data that you need? What's a minimal optimal data set of clinical data that you need to adequately interpret a genome? So it's, you know, how can clinicians really partner well with the laboratory scientists and bioinformaticians so that the interrogation of a genome is done appropriately? And so Zanitza and Richard Scott have been working on this consensus and bringing together, which I think there's now probably over 200 disease groups or clinical presentations for which those data sets are available, and we're obviously very happy to share those. Zanitza, put your hand up. And we're harmonising those between Genomics England and Australian Genomics. So there's been two different sets of minds in different hemispheres from different subspecialty groups working on this. And then looking at the technical infrastructure to actually capture that clinical data. And we heard earlier today about FHIR and how we're actually going to be able to capture data from REDCap into FHIR, and how eventually in a dream world we're going to be able to do that into our electronic medical records, which is the next challenge that we're facing. And then finally, this great idea of gene panels, and I hadn't really thought about this in this way until Augusto talked about it at the Toronto meeting of the Global Alliance, is it's really looking at when you've got a particular clinical presentation, what are the top prioritised proven genes that you should be thinking about to interrogate as a priority coming out of the whole genome. And so these gene lists, their benefits is they have this established clinical validity. The goal is that you're going to be looking where it's most likely you're going to find an answer first, really to try and improve that efficiency, because that's going to be the dream. The problem is if it's, I thought the example that Mark gave is that it wasn't this, query diagnosis of anemia that was really the handle. It was, if in actual fact, the intellectual disability part of the phenotype that gave the diagnosis of a thyroid deficiency. So you can't be too restrictive, but this is a good place to start, would be my take-home message. And so what we're doing now, and this is no minor tasks, is really between Australia and Genomics England. We've been doing it independently and now cross-comparing these gene panels, looking at the discrepancies, look at what should be included, and looking across these particular disease areas where we've both got lots of data. And I think what we're aiming at is just like we've got Matchmaker Exchange. If we can be starting to share variant curation along the lines of what ClinGen has been doing for many years, and I'm hoping ClinGen will move into one of these circles here, that we're actually sort of setting up this collaboration of how we're doing expert curation of variants to make sure what we're building on is accurate.